the skin part of the, I will only show you the skin part of the Invicision. Then going inside, Abhay will show you, and then the disc part, Sankalp will show you. Okay? Alright. So you remember this incision, right? It starts at the margin. Starts at the margin of the helix here. Okay? Quiet, please. Starts at the margin of the helix here, goes into the crux of the helix like that. Okay? And then at the time that you are placing the incision, you are pulling the skin forward. Suppose it's here. You are doing this, okay? You are pulling the skin forward, and then when you place the incision on the tragus, and then when you release it, actually the incision is behind the tragus. Okay, so you will not see that. Again, whatever I am saying will only make things more difficult for you. Okay, this is technically a difficult incision. You have to go from inside because your incision is behind the tragus. So from inside you have to come out because the tragus is like that. Come out like that and then go back again like this. It is difficult in the beginning, so you start with preauricular. But you just have to know this. Okay, so you pull the skin while placing the incision, and then you can come here. Okay, into the interdraging notch. Now, when you are placing your incision and raising the slab, this is very important. Okay, please don't forget to do hydrodissection because you need some space to place that incision. After the hydrodissection, you are placing the incision on the margins. This has to be leaving the perichondrium onto the cartilage. Okay, so the slab that you are raising is a supraperichondrial slab. Alright? So you start with that crux of the helix, then go on up, and then Abhay will explain up where you stop. I am only explaining a little more. And then you raise the perichondrium, raise the supraperichondrial slab. Once you get here, then you hold the tragus and pull it down so that counter traction, and then you are raising the slab. Okay, stop. Alright. Okay. Any questions only about this part? Alright? Okay. Now, whether you reach it like this or you reach it like when if you're doing a preauricular regular incision, it's just an incision here like that, okay? End oral is the same incision here, but you're going behind the tragus. Alright? Inside it's all the same.
He said inside is all the same. Two things, whether you do an incision or you do a preauricular, you are doing an end oral. The position of the surgeon plays an essential role. When you're doing your preauricular or your endoral or your incision, you're standing at the right side 9 o'clock position and doing your surgical practice. I will divide the incision into two parts. One is above the arch and the other incision is below the arch. Always start with your dissection process above the arch because you have your identification of your temporalis fascia, which will guide you to come downwards and make your life much more easier, rather than starting point being the trigger area where you start your dissection. So start by identifying above the arch the temporalis fascia. There are a lot of synonyms where we call it as temporoparatal fascia, which goes into the anterior flap, housing the nerve, and your deep temporalis fascia, which is there. There is an innominate fascia between these two, but I don't want to confuse you people going into the micro levels of fascia. So the first thing is you identify the temporalis fascia at the head end of the patient. Once you identify the temporalis fascia at the head end of the patient, the next thing what you can do is you're going to start your dissection above the arch. So when you start your dissection above the arch, what is that one component you're going to identify? Is the temporalis fascia. Once you identify the temporalis fascia, go back to Edward Ellis. He speaks about dissecting in an avascular plane. Now, where is the avascular plane? It's located in the precartilaginous region. So you stand at the head end of the patient. If she is the patient on the OT table, I would make a rent from the temporalis fascia. This is the exact position you need to take. Otherwise, you're going to get lost. Your STA, that's your superficial temporal artery, and your vessels, liability has to come in the anterior flap. Remember my words. So you start and dissect with a blunt dissector in an avascular plane, staying close to the tracheal cartilage. And remember yesterday, I and Dr. Andrew were speaking about external aortic meatus. At this
juncture, tell your assistant to put a hand inside the auricle so that you don't dissect medially and you open up the external auditory canal, because when you're doing a TJR or any fractures, if you open up, it's going to be a disaster. So stand at the head end, dissect the precartilaginous plane which is avascular, make a rent and gently keep a artery or a dissecting forceps there and release with your blade. Minimize the use of cautery. So at the end of the surgery, what do you need to see? You need to see a nice fan-shaped muscle, that's the temporalis fascia, above the arch and continuing all the way down so that you have a beautiful anterior flap. So once you have identified the temporalis fascia below as well, you might see the glenoid lobe of the parotid gland. Please remember, Siddharth yesterday spoke very well about the parotid. Respect the parotid, don't cauterize the parotid. Remember the distance from the external auditory cartilage to the closest branch of the temporal area, which is the most important for closure. Crowning is still okay, patients are not very much worried. But when you have a complication of eye closure, the patient is bothered. We would take it lightly, it's going to come back. What happens if it doesn't come back? It's an induced complication. So what you need to do is make sure you identify, stay in the precartilaginous plane, and then it's your choice. Once you identify the temporalis fascia, whether you want to give a 45-degree release incision from the root of the arch superior. Don't come from the top to the bottom. It's antero-superior, posterior-inferior. Are you with me? So once you expose the release incision there, automatically the fat pad is going to come into that area where the nerve is housed. Once you reflect, doing the obvegesa maneuver, keeping the periosteal or the ovals over the arch, don't reflect this way. Keep your periosteal here and lift. When you do this, I see surgeons use the cautery there, and that's the time you're going to cause an injury. The nerve is in the anterior flap. So you keep it here and lift up. Automatically, at that particular junction, if you need a little bit more access in the lower segment, dissect bluntly, but don't violate the glenoid lobe of the parotid. Okay? Is this clear? So dissection and standing at the head end to reach the precartilaginous, exposing the temporalis fascia in its entire substance, identify the root of the zygomatic arch, and then give your incision. Is that clear? Right. The next one to make that out. One is the 45-degree approach from the root of the arch to the top. The distance, remember, when you're doing this particular maneuver, you're reflecting what will happen in the anterior. Whereas what I do is, when I say mine, it's not mine, I picked it up from George Dimitrius. I've seen him do a horizontal incision right above the zygomatic arch from the root anteriorly just for a millimeter, 9 millimeters horizontal over the arch, and then to that horizontal you attach a curved vertical following the anatomy of the tragus and dissect into that flap. So you have a flap there which is open and you can see the entire capsule of the EMJ, and that's where Sankalp comes in to show us how do you dissect and get into the superior joint space. So there are two variations. One is the 45-degree approach and the other one is the horizontal and following the curvature of the tragus. It opens like a flap. These are essential maneuvers when you want to suture back. When your final suture is obliterating the dead space, this is a beautiful maneuver. When you have a case of ankylosis, you don't get any of this. But the most essential thing is your leeway to prevent a nerve injury from the tragus is just 9 millimeters. So within that 9 millimeters, you do what you want. When I say what you want, it doesn't mean we can be rash about it. What I mean to say is you are in a safe distance. Anything beyond 9 millimeters, automatically the nerve branching happens. The middle line, what you spoke about, the middle line, what we spoke about. Okay? So the main key is to divide the incision above the arch, below the arch, stay in a precartilaginous plane, identify the temporalis fascia, stand at the head end, dissect the precartilaginous plane, assistant keeping his hand in the auricle. As Andrew said, switch lights into the auricle to see the thinness of the external auditory canal. You never know where you're going to rupture. So we said yes. The finger dissection where?
No.
No fingers here.
Not
Fingers comes to an essential component when you go into the lower neck. Here there's nothing, you're just putting a finger inside the auricle.
I'll just show you this video again.
Go ahead.